as opposed to anything that imaging or testing or electrical evaluation or any other modalities that we use for other neurologic conditions can give us information on. It isn't that. It truly is the story of the symptoms that you're going through that really nail the diagnosis. Um, One of the things that I would say that I also like to reach out to this group is one of the things I've noticed over the decade, about decade that I've been in Michigan, and I'm not from Michigan. I just came here for running the skull base program uh, between Ascension and Beaumont Health. Um, and that's how I really came here. So I had no ties to Michigan, and it was actually the ENT group that recruited me over here, mainly to do work as it pertains to cranial nerve tumors like trigeminal schwannomas and vestibular schwannomas and things like that. And then, of course, in the process of that, given that location of work, trigeminal neuralgia is something that I was excited to help patients with. But one thing I've noticed in that journey, especially in this region, and as someone not from here, I was a little bit shocked, and I continue to be shocked at this day, how I want to say sort of mismanaged trigeminal neuralgia is. Primarily because I think sometimes people really just fail to nail the diagnosis, or they come across it really late, or when they think about treatments outside of medical management, it's often in the very late stages when people have already been quite disabled from some of the medications that are utilized to treat this. But the first thing I like to emphasize and evaluate when I see someone is this truly trigeminal neuralgia? Because there is trigeminal neuralgia, and then there is non-trigeminal neuralgia facial pain, is the best way to sort of define it. Some people call it atypical facial pain or type 2 facial pain. There's all these different criteria about what that is. But it's important to distinguish trigeminal neuralgia from all the other facial pains, because trigeminal neuralgia has a very defined treatment path, and not all facial pain should be called trigeminal neuralgia, because otherwise I think patients end up getting a lot of the wrong treatment when, like I said, trigeminal neuralgia has a very defined treatment path, but the non-trigeminal neuralgia facial pain does not. And for trigeminal neuralgia, it truly is a lancinating, one-sided facial pain that usually involves one or two distributions, so not usually the entire face, um, that has triggers such as wind or air or touching the face or chewing, talking, eating, these sort of triggers. Uh, Certainly, just by the nature of stress and motion, those things can activate it as well. But those things have to be there, I would say, to meet the diagnosis of classical trigeminal neuralgia that has the treatment path of the medications like you probably heard of, the neuroleptic treatments like Tegretol or carbamazepine or oxcarbazepine or trileptal, baclofen, gabapentin, all these kinds of things, because those things tend not to work in non-trigeminal neuralgia facial pain. But patients who have constant pain with associated numbness or sometimes problems with movement or spasm in the face, and this burning, dull, achy kind of pain that's always there, that doesn't go away. It's there when they go to bed, it's there when they wake up, and it doesn't have any triggers generally, and it just comes out of the blue sort of pain. That is non-trigeminal neuralgia. That is, you can call it atypical facial pain or type 2 pain, but it's not classical trigeminal neuralgia. And therefore, neuroleptic medicines like Tegretol, trileptal, those kinds of medicine tend not to be as effective in those patients. And furthermore, ablative treatments targeting the trigeminal nerve, like radiation or percutaneous procedures with needle-based treatment or microvascular decompression, also similarly don't help that situation, and in fact can sometimes worsen it in some cases, because the pathway of non-trigeminal neuralgia or atypical facial pain is centered usually in the brain as opposed to at the level of the trigeminal nerve. Whereas trigeminal neuralgia, the classical lancinating electrical facial pain that has these triggers that sometimes generally respond to carbamazepine, trileptal, are rooted structurally in the trigeminal nerve itself. And that's where those treatments are targeting. But if you do that in this other type, it doesn't work. And I see all the different versions of this in the clinic, every clinic. And I'd say that's always the challenge to me, that it's amazing how many times things are labeled trigeminal neuralgia when they're not, or things are trigeminal neuralgia and then they're not being treated appropriately. So once that diagnosis is established as trigeminal neuralgia, I'll talk about that first before talking about non-trigeminal neuralgia facial pain. So that lancinating, intermittent, on-off kind of lightning bolt-like facial pain with triggers. First-line treatment is medical with neuroleptics like carbamazepine, because those medicines are designed to reduce the excitability of nerves. And so nerve-generated pain tends to respond to that. I also like to use that as a way of trying to nail the diagnosis, because if it's at least partially responsive to Tegretol or carbamazepine or trileptal or one of those kinds of medicines, even if it's a little responsive, that also goes along with nailing the diagnosis as classical trigeminal neuralgia, whereas those medicines don't work at all. But it's also important for me to distinguish, is it that the medicine isn't working, or did someone have just such profound side effects, which is so common with those medicines, that they couldn't even figure out whether it was helpful? And those are the things I like to figure out in the office visit before going down a treatment path. So assuming that someone does indeed fit the description for trigeminal neuralgia and we go down that pathway, there are two types of treatments. One we call ablative, and that's where you essentially try to knock down the excitability of the nerve. And the ways to do that would be with either focused radiation. Sometimes there's percutaneous procedures where we use a needle and localize the needle to the level of where the trigeminal nerve exits the skull, and use thermal energy, that's called radiofrequency ablation. Or sometimes you can use a balloon and essentially traumatize the nerve, if you will, to knock down the excitability. The negative of those kinds of treatments is they're usually not as durable as the non-ablative treatment, which is microvascular decompression, which I'll talk about next. But the ablative treatments, which include gamma knife radiation or percutaneous treatment strategies or balloon dilation, those kinds of things are designed to effectively decrease the excitability of the nerve, but it doesn't treat the actual problem per se. It just reduces the excitability in an attempt to reduce the medication. But most patients who undergo that, not all of them, but I'd say the vast majority, don't usually become pain-free off medication. They're usually pain-free with reduced dosing. But ultimately, those treatments, because they just reduce the excitability as opposed to trying to fix the underlying condition, ultimately have a certain durability, at which point the pain then recurs, and depending on how much benefit they got, we can redo those procedures. Oh. The next line of treatment, and which is sort of the gold standard for classical trigeminal neuralgia, is microvascular decompression. And this is a treatment that's been around for decades, it turns out. It's been optimized to this date to be a more minimal access and much sort of safer, straightforward, faster kind of operation than earlier. But all that said, the operation is still very much the same, where it was discovered by Peter Janetta at Pittsburgh years and years ago that vascular contact of the trigeminal nerve at the level of the brainstem actually is the cause of trigeminal neuralgia in those people who have trigeminal neuralgia. I say that because not everyone with vascular compression will get trigeminal neuralgia, but I'd say people with classical trigeminal neuralgia tend to have vascular compression at the brainstem exit of where this nerve leaves the brain. Now, oftentimes, as a first line, we like to get MRI scans in everyone with trigeminal neuralgia to make sure they don't have another problem like a brain tumor that we occasionally see, usually benign tumors that can compress the nerve, like meningiomas or nerve tumors and things like that. That's more rare, I would say. And oftentimes people get the MRI scan and the radiologist reads it as negative. But it turns out, even though it's reported as negative, and these people are then, often not sent to a neurosurgeon because the radiology reports said normal MRI, patients with typical trigeminal neuralgia symptoms still have vascular compression. And that's an important thing. And I think that's where the diagnosis is missed and the referrals are not made appropriately, because oftentimes they get an MRI and the radiologist says it's negative, but the radiologist isn't looking at it from a surgical eye, because blood vessels always live around nerves. That's nothing unusual. But when you're looking at it from a neurosurgical standpoint, even though all blood vessels live around nerves, I'm looking to see whether the nerve anatomic pattern is indeed compressive or not. And that's not something a radiologist typically would look at unless the nerve is really being kinked by this vessel. And that finding is also rare. But the majority of patients with classical trigeminal neuralgia that were initially responsive to things like Tegretol, who have a normal MRI scan, actually have profound vascular compression. It was just reported as normal. So that's why it's important for neurosurgeons like myself to look at it to see if indeed that is the case, or was that just a misread by the radiologist. Not a misread, because like I said, blood vessels always live around nerves. But for a radiologist, that's not abnormal. But for a patient with trigeminal neuralgia, that could actually reveal the pathology. And so a lot of those patients fail to be seen by neurosurgery, unfortunately, because they have a fairly curative problem. Because when I look at an MRI scan and I do see vascular compression in people with typical trigeminal neuralgia, the vast majority of patients, that surgery is indeed curative, meaning pain-free, off medication in the vast majority of patients. And that's an operation done with people asleep in the operating room, so we do it under general anesthesia. And even though it's a brain operation, it doesn't have the major risks that are associated with classical brain surgery. And I think that's another misconception that sometimes neurologists, pain management doctors, and people like that have, probably because they've seen complications when it's done by teams that are inexperienced.
Alexa off Fahrenheit and a low of 64 degrees.
And sometimes because they may have seen complications in scenarios where it's done by teams without much experience, but actually in an experienced situation, that surgery is a very clean, safe operation that really just involves the trigeminal nerve and has not much to do with the brain at all. And it's not the recovery of a typical brain operation, because it's all involving the nerve at the level of the cistern, which is a bloodless field where people recover from this with just 1, maybe 2 days in the hospital and are immediately better from it, for it after having done the surgery. And we can start weaning the pain medication fairly quickly and likely get them off of medications like trileptal or carbamazepine. And so that is the gold standard of treatment in the appropriate candidate. And so those are the treatments for classical trigeminal neuralgia, the electric shock-like on-off pain that's not constant or burning, that has typical triggers like cold air, wind, chewing, talking, eating. And also I look at age of the patient, because if facial pain starts to, because trigeminal neuralgia generally is a condition of patients over the age of 45 and 50 plus. If I see it in younger than that, I have to think about a different variant of facial pain, because that's pathophysiologically, it's not common, although not impossible, common that like a 22-year-old would get trigeminal neuralgia in the classical way. Usually that would then fall into the next category, which is non-trigeminal neuralgia facial pain, sometimes called atypical facial pain. And it's important to make that distinction because the treatment is entirely different from all the things that I just mentioned before, like gamma knife, microvascular decompression, percutaneous things. In atypical facial pain, where usually it's a constant burning, almost full-sided pain on one side of the face, where all 3 distributions are involved, or sometimes people say it involves the head, and can then radiate down into the whole face, and it's constant and always there. And they go to bed with it and wake up with it. In those situations, I would say if you utilize trigeminal neuralgia treatment strategies, patients tend to do worse. It's reasonable to trial something like carbamazepine to see if there's any benefit, but usually there isn't. And people have to be treated with things that target the brain, because that's the origin of atypical facial pain usually. Either the thalamus or parts of the motor cortex that can cause this pain to evolve. And so that's the first thing, is to distinguish the two things and then get people on the right treatment path. Sometimes ablative treatments can be done for atypical facial pain, the constant type, but the efficacy is less predictable than classical trigeminal neuralgia. I will say that atypical facial pain is a challenging thing to treat, because all of the treatment has to usually target central things like the brain and the thalamus. And those are just difficult to target. People have looked at using things like motor cortex stimulation or functional pain management with stimulators, and to modulate the pain center and the pain response, and that can be effective. And we can do trial-based treatment to see if someone's a candidate for those things before embarking on implantation of devices, or treating with other central nervous system brain targeting therapies. But that is the most challenging type of facial pain that I encounter, because the treatment of it is less predictable, because the target is less clear. So that's the kind of the general overview of trigeminal neuralgia and how I see people with it, and then how I recommend treatment and how I go about that. And so I'm happy to take any questions from anybody about anything that we talked about.
Does anyone have any questions?
Either for me personally about my practice of trigeminal neuralgia, or even about your own condition. Any of that is
Hi,
fair.
doctor. My name is
Hi.
Roseanne. I have a
Hello.
question.
Yes.
My husband is a TN patient and has been since 2016, but it's become very confusing. When he has the classic shocks, radiating through usually V2 and 3, sometimes V1, it depends. He's been on carbamazepine since 2016 and has responded to it. At around 2020 possibly, or 2021, I do forget years, all of a sudden the pain came back full force. But he was on carbamazepine for over 5 years and it worked well. He had to increase the dosages, but for the most part it worked, and then it came back. We sought out a few surgeons within our area. We live in New York City, and all the surgeons that we had seen came up with the idea, said that microvascular decompression is the way to go. He did have a microvascular decompression in the October of that year. I believe it was 20. And after 3 weeks, the pain came back worse, and came back in multiple other areas. The doctor had said, due to surgical, manipulation and inflammation, just give it some time. By January, the pain was 1,000 times worse. So we sought out another surgeon who felt there was another compression under the trigeminal nerve. It was missed, or possibly it was due to the first surgery. My husband could not stand to do another microvascular within a couple of months. So the balloon compression was suggested and done. And the balloon compression, solid 9 months of no pain at all on carbamazepine, because my husband was just deathly afraid to get off of it, but a reduced level. At 9 months, he had COVID for the second time, and the pain came back. So we were told to increase the carbamazepine, and again, it kind of lulled it. Our neurosurgeon has since retired, who said that who did the balloon compression and said there was another compression under the nerve. Now that we're seeking out other doctors, again, we live in New York, so we've been seeing local doctors. The diagnosis is now because he did fall in 2016, and that's when the pain started, that it's post-traumatic neuropathic pain. So that's something in a way completely different based on treatment. So
Mhm.
we don't turn. So now he's being treated as not a TN1, classic TN1. He's being treated as a post-traumatic neuropathic pain due to the fact that the area is always red, his cheek is always red, and the point that he fell. So I feel like we're at such a loss because we're having two different diagnoses, and I tend to think it's because he had a microvascular decompression already that that the other surgeons don't just want to touch him. So it's not atypical. He's having shocks. It's when exactly what you said: wind, pressure, tension. If he gets nervous, eating, chewing, brushing teeth, touching. We were under the impression it was always classic TN1, but now we're told it's post traumatic, and his medications they want to change his medications. So we just don't know the route to go.
And he's still responding to the carbamazepine. By that I mean, if you were to just stop it, the pain would absolutely get worse.
Yes. So we already increased it from 1,200 milligrams to 1,800 milligrams. And now we're trying to lessen the 1,800 milligrams because the doctors had said that's way too much. So they added Cymbalta and Lyrica. We just started those within a month, and we're just going to increase the Lyrica to 2 pills a day, and then wait a couple of. The doctor said wait 5 more days, and then try to reduce the carbamazepine. But my husband's still getting shocked, not as much, but
Right.
he didn't get them as much with the 1,800. But the thought process is, well, we have to keep increasing to 1,800. We had to increase to 1,800, and you are still getting shocks. But we went from having shocks all day, every day, to now just a few a day. So we're very confused, and I think they're on the fact that he did fall. And he compromised the whole right side of his body. His whole right side of body was basically crushed, but that he did fall and he did slam his face. So that's what they're saying. It's post-traumatic neuropathic pain. But how do we,
Does he have numbness in the face?
I'm sorry, I didn't hear you.
Does he have any numbness in the face?
He did,
Sensation.
but not anymore. The numbness has gone away.
He did when, sorry?
He had numbness when he had the balloon compression.
Got it. Yeah,
Yeah.
I would expect numbness with the balloon compression. But usually if it's post-traumatic, oftentimes if it's just a fall, unless he cracked his face in such a way it went through the base of the skull where the trigeminal nerve sits, usually patients in that situation have numbness at the time of the pain. And it's more of a constant kind of a pain. So that, and it's not generally responsive to carbamazepine. Based on your description of his history, and how old is he?
Well, now he's 59, but at the time it was 2016, so eight years ago.
Okay.
Mhm.
I mean, it doesn't sound to me like post-traumatic neuropathic pain from the descriptors, even though there was a trauma surrounding
That's what
that. And also, it's really rare for typical trigeminal neuralgia to get microvascular decompression that only lasts weeks. That would be highly unusual. So I would say the fact that he's still responding to Tegretol or carbamazepine and does not have any numbness and has triggers, I would still look at it like classical trigeminal neuralgia. It just doesn't fit to me like post-trauma.
That's
It doesn't have
we
features.
feel that way also. And again, we don't have this, again, the doctors we've seen aren't agreeing with that. They're just keep saying, well, now it's post-traumatic. I said, how did it change? And I know they did give me an explanation, but I would never even be able to remember what they said.
Yeah, I mean, my suspicion is because all the things they were doing for typical trigeminal neuralgias seemingly not durable and effective, and therefore they're questioning is that actually the story? That's probably sounds like.
MVD in the first place, but the second neurosurgeon that we sought out said, well, the reason is because there's another compression that was missed and
they
ha-
didn't want to do MVD revision?
no, neither one of them will even attempt. The two surgeons we saw recently won't even discuss MVD.
Because
So-
revision MVD is not a prohibitive thing to do in my view, in my experience. It just depends on the MRI findings to see if there's any meaningful benefit to be had by doing that. But if there is such a benefit that's meaningful and seen on imaging, I don't think that's a unsafe thing to do.
Right. Both had said that they don't feel that there is a clear compression, that there is a vessel under the trigeminal nerve that is close to the nerve, but it's not compressing it. So he had a Fiesta MRI, so they're basing it on information. So we're just, we're going now with different medication, but in my heart of hearts, I just feel like it's TN and they're treating it in a post-traumatic, and they said not the treatment plans would be different. Ablative surgeries wouldn't work, exactly what you said, MVD wouldn't work. So now we're just trying medication because, again, we're relying on two certain neurosurgeons that are here.
Yeah. My thought about it would be if indeed there was some suggestion of compression medial to the nerve, as it sounds like they're describing, meaning on the inside part of the nerve, then a revision MVD would seem appropriate and reasonable prior to definitively, with an experienced person who's done revision MVD or familiar with MVD in a big way, only to know that the next attempt at surgery is indeed done, as best as possible. So at least we can be rest assured that we've maximized that treatment before embarking down just medical management.
We even asked for another MRI because something could have changed and they didn't agree to that. So we're kind of like at that loss, but we will seek out.
Yeah, that would be the best recommendation, would be a follow-up MRI with Fiesta and deciding whether a revision is appropriate or not.
Thank you, doctor. I appreciate your opinion. Thank you.
Sure.
Does anyone else have? Yeah, Regina, you're muted.
Okay, doctor. Good evening. I recently had a radio frequency percutaneous. I can't remember the next part.
Yeah.
The day after Mother's Day, surgeon said it was not successful due to the fact he was not able to advance the catheter. Initially on the consultation, I asked him about MVD, and he said he would not suggest that because of the previous diagnosis I have of multiple sclerosis. So what is your opinion? Why would he not have been able to advance the catheter during the procedure? And am I not a candidate for MVD? That is my question.
Yeah, Regina, so multiple sclerosis, I hadn't touched on that, so I'm glad you brought that up. If there's one condition that's predisposing to trigeminal neuralgia, because most trigeminal neuralgia actually does occur spontaneously, but in MS, due to demyelination, patients are exquisitely at high risk of developing facial pain, both typical and atypical, due to the demyelination. And in those patients, I first evaluate, is it typical or atypical, even in an MS patient, because MS patients could also, if the imaging is consistent, benefit from MVD. But in patients who don't have those features on imaging, then generally ablative treatments are favored in MS, only because, and then for also the other thing we need to make sure of is to make sure the MS plaque is not involving the root of the trigeminal nerve itself at the brainstem. Because then all those things have to be kind of sorted out in MS patients, because we don't want to do MVD or things like that in an MS patient if the demyelination is actually the primary inciting factor, because then no matter what you do, the demyelination phenomenon takes over and it remains hyperexcitable despite how you either ablate or decompress the nerve. So I try to look at, is there MS at the brainstem where the trigeminal nerve exits? Is there vascular compression? What's the response to things like Tegretol or carbamazepine? And I have some MS patients who I do indeed treat with MVD, and many that I treat with ablative treatment, whether it's gamma knife or percutaneous. As far as why they couldn't advance the catheter, I don't have a definitive answer for that, but I mean, usually the way that procedure is done is we use fluoroscopy to look at the foramen ovale, which is the part of the skull base that's a fairly open landmark that you can advance the needle to. And then you can get spinal fluid back, which allows you to know that you're indeed in that segment to begin the ablation. The fact that they couldn't, factors could be either the scarring at the level of foramen ovale, but it's usually in people who've had prior percutaneous procedures. And usually after 2 of them, that area can sometimes scar. Sometimes it doesn't, but sometimes it can scar over such that you don't get spinal fluid feedback to know whether you're in that space. Or sometimes there could be some anatomic variant at the base of the skull, I suppose, that could also account for that. But usually you would know that on imaging prior to the procedure. But those would be the only things I could think of.
Also, he suggested maybe to hold on. I haven't had any more of the shocks in my brain, and I'm eating better, but I still have pain. And it's not as severe.
Mhm.
Because of tactile, touching.
Yeah.
He suggested the next step, to hold on, maybe wait 6 months and maybe radiation
So I
treatment.
think in a scenario where you, especially with MS, if you had at least a partial response, I think that is a reasonable advice. Because in MS, we know that the management of facial pain is going to be very long term. And doing repeat intervention in such rapid sequence could then burn bridges for intervention later on. And so I think if you've reached a level of at least tolerance in some way relative to the way you were pre-op, I would think that's sound advice to sit tight and consider gamma knife potential several months out. But has the advantage that it doesn't cause scarring, at least as far as repeat percutaneous procedures, and it doesn't cause sensory abnormality like numbness in the face like radiofrequency can. So I think it's not an unreasonable thing to look at several months out, because you don't want to do too many treatments in rapid sequence to achieve perfection, especially in MS, because you could be burning a lot of opportunity for treatment later if you have an MS-related exacerbation.
My next comment,
Mhm.
during the procedure, they advised me they would have to wake me up to see if he's in the nerve and then put me back under. Why is that?
So I used to do it like that early on because that's the classical way to do it. So in the classical way to do radiofrequency or any needle-based procedure is to do sedation and numb up that area, advance it, and then reposition the needle to see if you can mimic the pain distribution before doing the thermal ablation. I've found that that makes most patients very uncomfortable, and it's kind of traumatic and painful. And sometimes the anesthetic that's being utilized doesn't hold, and people get really kind of uncomfortable in that situation. So it becomes harder to do. And so I generally don't do that. I will anatomically target the needle um, depending on the angle and the where it's sitting in the foramen, and then just proceed that way, just because I find patients obviously tolerate it better. I don't have to deal with issues as it might pertain to pain that then requires a different kind of anesthesia that then makes people really sleepy and airway issues associated with that. and just the overall trauma of doing that to someone. But that is that's the classical way to do it, is like they described. Wake you up, test the distribution, and then put you back to sleep.
Thank you.
Yes, Katie?
Hi, Dr. Jacob. Thanks for
Hi.
addressing us. Hi. I just had
Hi.
a quick question about, and you may have addressed this already. When you're doing MVD, is it typically the suboccipital approach that is taken versus like a transtentorial approach or something else?
Generally not transtentorial unless there's a tumor that's involving the entire segment of the trigeminal nerve from brainstem up. For MVD specifically, it's what's called a retrosigmoid approach, which is effectively a variant of the suboccipital approach. It's just more targeted.
Great, thank you.
Sure.
I had a question. I had a question, Dr. Jacob.
Yeah.
Where does hemicrania continua fall with the like atypical facial pain area, I guess? Because the reason I ask is because I was diagnosed at first with atypical facial pain, and then after I developed shocks that were not with typical triggers, I had a pain management doctor say hemicrania continua. And the other, I think it was because I was photosensitive and sound sensitive. Can you comment on that? Where does hemicrania continua fall within the realm of TN and ATF, atypical facial pain?
Right. So when it comes to non-typical TN, all of these terms kind of fall into that realm. So depending on where the pain is located, if it's outside the trigeminal distribution and then up to the top of the head, people may use hemicrania continua in that spectrum of non-trigeminal neuralgia pain. In traditional neurology, in people who manage sort of migraine phenomenon, hemicrania continua has very specific sort of treatment or specific sort of clinical findings and management strategies. But I think the problem, of course, is when it doesn't fit in the bounds of trigeminal neuralgia, all of a sudden the triggers of pain become central, becomes brain, thalamic, even trigeminal vascular, but not like trigeminal neuralgia, like a classical scenario, but a more vascular type of situation where migraine, complex migraine, hemicrania continua, atypical facial pain, all these terms get thrown into that picture as people are trying to sort out the target. I guess that's the best I could say. But all those terms get thrown because the target becomes unclear and people are trying to figure out the target, calling it, maybe trying a different strategy to see if that'll address the problem more effectively.
I like your wording of the way you said it's trying to address the target. Is it central? Because that's what I feel like I've been going through. It's more of a central thing because I get shocks now when I'm concentrating heavily, or I'm not heavily, but listening. I can last in a conversation for 15 minutes and then that's it.
Right. And that's the problem. The central targets are very complex because anytime people have tried to look at that, it changes from patient to patient, even with similar pain scenarios. And that's what makes it awfully challenging because it's a lot of trial and error and oftentimes not with pain freedom, just with some kind of tolerance.
Okay, that's kind of where I'm at.
Yeah,
It's a crapshoot to figure out, you
fortunately, that's
know.
the most difficult thing. Because again, the target is not clear, but then it's not clear if we can ever find a target, because anytime they've looked at that even, that tends to vary a lot too. Neuromodulation, deep brain stimulation, or other things like that, stimulator-based technologies are starting to become more of the mainstay, but even that is not very predictable in terms of its outcome or efficacy in that situation.
I'm gonna donate my brain or my body to science, maybe my brain at least.
Right.
So a student can figure it out in 20 years. So
I
people
hope
don't
so.
have to go through this crap.
Right.
Thank you, Dr. Jacob. I appreciate it. Thank you very much.
Mhm.
Dr. Jacob, what about Botox treatments?
In classical trigeminal neuralgia, I think Botox, because it can have an effect where it reduces nerve excitability, has a role to some extent. But for classical trigeminal neuralgia, treatment is so much better using the other modalities, I would say. But I think if the Botox operator is experienced in doing that, I think it can have some benefit depending on the pain phenomenon that people are experiencing. But in typical trigeminal neuralgia, I would say it's generally not effective.
Okay, thanks. And when do the patients come back in your practice for, if the for follow-up or further?
Yeah, I mean, so it depends on the situation, of course. So for classical trigeminal neuralgia, um, especially those who have MVD, for instance, fortunately, I don't see them back often, only because I see them at, a 2-week check. And then usually they call us if they have any issues, because I don't want to subject them to waiting to see me, or, coming from long distances and stuff like that, only to say that they're doing okay. So I usually don't see them back unless there's an issue. And fortunately for classical trigeminal neuralgia, meaning non-MS, typical trigeminal neuralgia with MVD, generally the durability and efficacy is quite good. So I don't see them often at all. In people who have MS or received an ablative treatment, the durability in that situation is less so. And so sometimes, generally, I like it if people can go 5+ years off of a treatment, because then that allows for different treatment strategies over time. That's kind of how I gauge it. They come see me when there's a recurrence of pain. But usually in the typical MVD classical scenario, that's very rare.
As you know, seems to be worse at the beginning of spring
Mm-hmm.
and fall. So I'm
Mm-hmm.
thinking like I should have gone during the worst part of the season for me, the beginning of spring.
Right. I mean, I think in your scenario, I think the probably the worst thing to do is jump into multiple treatments really quickly. I think that would probably be fraught with more problems. Because I think if you notice some seasonality to it, it'd be good to kind of figure that out, and then either do a short burst of steroids or something to get over that initial inflammatory phase and let it die out again. And if you can get a situation where you're, more pain-free than not, and can tolerate things, and then can only utilize intervention in the terms of severe exacerbation after a whole length of time, that would be the best way to go about it. The time that people fall into trouble is they get repeat treatments really quickly, trying to get to zero and off pain medicine or something, and then you burn all your bridges really fast. That's a difficult situation, particularly in MS.
My neurologist would not prescribe steroids. I had to go to urgent care.
Wow. Why was that?
Just says it was not, she is not an MS exacerbation. That was her argument. And
Right.
my previous neurologist 11 years ago would always, once a year, give me some oral steroids.
Yeah, I think a short burst of steroids, especially
Yeah.
in that kind of frequency, once or twice a year, isn't a
Right.
harmful. Yeah.
Right. So for me to have to go to urgent care is terrible. I could not speak. My speech was garbled. I wasn't eating, I lost a lot of weight. It was bad.
Hmm.
My next
Yeah.
step was gonna go to the emergency room,
Right. Right.
get
I think
IV.
even though MS exacerbation is treated with prednisone and things, in acute trigeminal exacerbation, it can be helpful as well. And if that's utilized in a infrequent basis in the appropriate setting, I think it can be powerful and useful.
Hopefully the weather will stay steadily warm here. I'll be fine. I'll move south.
Right. Right.
Thank you.
Mhm.
Dr. Jacob, you made reference to when the onset of trigeminal, classical trigeminal comes on, having something to do about, is it real, classical or not? I'm 80 now. The best I can figure, I was 35, somewhere 35 to 40 when it first hit.
Mhm,
And
mhm.
I had an MVD done in 2002, and
Mhm.
it lasted for 3 months, and then the pain came back. And a few years later, I had the microvascular decompression. And to my memory, it took about 6 months before the effects really took place. But from then on, for 16 years, it was on the basic level of medication, and otherwise, no problem. And
Mhm.
then when it did come back a few years ago for 4 or 5 months, again, it was not sharp pain, but it was severe enough that my neurologist put me on 2 more meds, and then it just stopped.
Mhm.
And I went for 2 years with no problem, but then last October it came back in big force, and it was on and off awful, and I finally ended up in the ER too, and they added baclofen to the trileptal. And
Mhm.
so then after a few months that took effect and I was without the pain, things were getting much better. But then they came back in March, and finally early in May, I went through the gamma knife ray again. And right now I'm at the point where it's pretty well subdued. Although this time the left side of my face started acting up. It's not now, but I can eat regular food. But like even today, I could feel some things in the right side of my face, not outright, nothing horrible, but just making its presence known,
Right.
And I just wondered if you had any comments on how long I've had it compared to, does that give any idea of what's,
Yeah. I'm glad you asked, because that helps me clarify my point about the age. Not that younger age means it's atypical in the typical atypical, where it's constant burning kind of pain or distributions don't match, but when it starts prior to the age of 50, I have to think of it a little bit like I think about atypical, meaning as a very chronic management, because oftentimes if it presents in 20s or 30s, like in your case, there's oftentimes a recurrence of pain at various points in people's lives, as you've experienced, where you've had at least one gamma knife and two gamma knife and one MVD, it sounds like.
yes.
Um, and so, I think the way it's managed sounds very reasonable, in the sense that, and it also speaks to the fact that maybe why you didn't get such robust long-term benefit with the MVD. It was just a few months, and then needed a more ablative type treatment like gamma knife. And then the gamma knife went several years, and then another repeat one after a certain years of elapse is reasonable to do. But I think the way it's being managed in your case is the right way, where you're not getting way too many procedures, between 35 and age of 80, but just enough to kind of control things in moments where you may need to get another many years out of it.
Okay.
So that's what I think I try to keep mindful of, meaning at 35, if someone sees me and has trigeminal neuralgia, I presume that I will need to be treating them, provided I'm still working, until they get to the age of 80 and beyond, because they'll have various points of needing intervention. And that's why in those patients, I'm particularly careful about now not doing multiple interventions in a short period of time
Okay.
and letting things ride itself out in moments of exacerbation, so they're not burned from every interventional option by the time they're 44. Because then it becomes a very difficult problem to treat and manage.
Okay.
Mhm.
Thank you very much. I
Sure.
appreciate it.
Yeah.
Actually, that kind of goes along with what my next question was about ablative procedures, doing multiple ablative procedures because of the shelf efficacy of those. What
Mhm.
is that the wrong, not a good approach to continually do ablative procedures to continually damage the nerve? Does that fall short for later interventions if the nerve is, again, repeatedly damaged?
It can, because if you do repeat ablative procedures, ultimately you run the risk of something called deafferentation, where the nerve is now no longer conducting sensory input at all. And then the problem becomes true anesthesia dolorosa, which is where it becomes a centrally driven phantom pain phenomenon that only narcotics can typically treat, and becomes a really challenging problem. So deafferentation, or disconnecting that pathway, is a risk of multiple ablative procedures. So I think there has to be a fair length of time in between those things and used in the appropriate setting, or you run the risk of causing deafferentation early on in someone's life.
Would you
Any other
then
questions?
suggest medications what other type of procedures in the interim of
The one
doing?
benefit of well, that's where in your specific case, potentially, depending on how much time has elapsed and what the imaging looks like, potentially revision MVD may be a reasonable thing, only because that's not ablative. And there's decisions that the surgeon can make on behalf of the patient to limit the risk of deafferentation, and then utilize ablative things later, and combination of medical and all these kinds of things should they need it. Anyone else? Any other thoughts, Aaron and Danielle?
Well, no, I don't have any other questions.
Kim, I see you unmuted. Did you have a question?
I just wanted to thank you, doctor, for your time and
Yeah,
me thinking about different things. Thank you.
appreciate it.
I think this has been extremely helpful for the group
Yes.
to be able to hear some of your expertise and be able to answer some of their specific questions. I think it's been invaluable. So thank you so much
Sure,
for
absolutely.
coming and presenting and answering all of our questions. Much appreciated.
As always, I'm happy to talk to the group at various times. Just let me know if that would be helpful,
Mhm.
either as a Q&A kind of thing, or I used to early on, I would show like videos of MVDs and this kind of stuff, but I think most people can YouTube a lot of that kind of stuff and different variants and all this kind of things. So I find it better to just kind of talk to people about their symptoms and kind of how I manage it. I just feel like it's easier to connect that way, but happy to
Yes.
the other time.
Yeah, you've given a very good whole picture and breaking it down, why this, why this, why this, that it is all in one. I appreciate it very much.
Definitely my pleasure. All right. Well, thank you all for listening.
Thank you.
Yeah, thank you,
so
Dr.
much. We
Jacob.
Appreciate it.
Thank you for
Really, really
coming.
great
Here.
for your time.
Right.
Thanks.
So, I don't know if we have any other things we want to cover, agenda wise. I don't think we really had much.
I didn't have any of the announcements to talk about.
Okay. I think they're all just kind of the regular things we put in there, right? It's
Yeah.
like,
Exactly.
yep, okay. All right. So does anyone want to share anything more about what's going on with them and?
Up to your surgeon, Aaron?
Let's say that again.
Dr. Jacobs, your neurosurgeon that you've been seeing? I've never heard of him and he sounds wonderful.
No, I haven't been to Dr. Jacob yet, but I was thinking about it because he does know a little bit. He does know a lot about,
Mhm.
I guess, a variety of things, and he might be a good person for me to talk to.
Yeah.
Though I haven't been able to find another neurologist that really is knowledgeable, or a neurosurgeon that's knowledgeable at TN that I would go to.
And when he comes, I think he tends to talk about the typical TN and Aaron's is atypical,
Yeah.
but,
Do we want to continue recording?
oh, no, we need to, we can stop the recording.
Okay.
Thanks for
You might
reminding.
remember that I was signed up to have my MVD with Dr. Jacob. But then I ran into problems with the insurance covering it, and